Welcome to the Hologic Symposium. My beloved Emilia, I heard a rumor about something related to moving from the dark ages to the light. What do you think it is expected here?
Oh. My dear William, based on the fact that HARTUS is so innovative, I believe that we are going to witness a very interesting session on the use of the Hologic advanced technology to treat intrauterine pathology under direct visualization.
Great! I like new technology, even feel excited. So, let's go for it. Can you please introduce the chairperson of this symposium?
Of course, dear. Our chair is Professor Sergio Haimovich, one of the co-chairs of HARTUS and the global community of hysteroscopy. He is also the immediate past chair of the AAGL Special Interest Group on Hysteroscopy, and currently working both in Spain and Israel. Please, Professor Haimovich, the stage is yours.
Oh, here I am. Thank you, William, and thank you, Emilia. By the way, she was his lover and muse, Emilia Bassano. So thank you for the introduction. So as I said, we are going to move from the dark ages to the light. So if we were talking about AI, so I don't need to make the introduction for the speakers. What I did is something different. I made the speakers introduce themselves. So let's see. Sound.
I am a board member in the Italian Society of Minimally Invasive Gynecological Surgery. I am also a faculty of the Master in Medically Assisted Reproductive Techniques in the University of Florence. Member of the board of the Italian Society of Gynecological Endoscopy. And of course, I enjoy performing many hysteroscopies during my practice at the Department of Gynecology of the Villa Donatello Hospital in Florence.
Dr. Castellacci will talk about the application of the MyoSure, a tissue removal system device, in reproductive age. And you will see that her voice, I cloned her, it's her voice. So, Dr. Castellacci, please, the stage is yours.
Good morning, thank you very much. I'm very glad to stay here, and thanks to Sergio, to Luis, and Attilio. And now you listen my voice, but it's really the same of the presentation. Okay, so let's start with the presentation regarding the first presentation, that is the use of the dispositive of the MyoSure. But anyway, even if it's sponsorized presentation, I would like to show all kinds of instruments that we can use in hysteroscopy. Here we see how many pathologies we can have in our uterus. I speak for ladies, for women, but anyway, here you see how many pathologies we can have and how many we can treat by hysteroscopy. And which are the instruments that we can use in our platform in study? But the first one maybe is the more known, that it's the thinner, the classic 5 millimeters hysteroscope that we can use in vaginoscopy, or the other that is 3.5 millimeters, very, very thin. And we arrived to the other that we can use in operative room that need the dilatation of the cervical canal, that are the classic resectoscope of 26, 27 millimeters. And then arrived after, in these new last years, two different kind of instruments that are a bridge from the outpatient philosophy that we use in office hysteroscopy, but has the characteristic of the classic instruments that we can use in operative room. And these are the mini resectoscope and the shaver one. And which is the philosophy, especially now that we have problems in our hospital, that we don't have anesthesiologists and we have problems with the operative room. The ability to improve the operativity in office setting, so improve the philosophy of the see and treat. And obviously, the advantages of the vaginoscopic approach, we know all of us. But we have to remember, first of all, which is the main topic when we start with the vaginoscope approach, that is to reduce the pain. So we have to put in our mind always that we have a patient awake and we have to perform. We have to ask if it's possible to do operativity for the pathology that she has. So we can have waiting time, reducing it's important for the patient, or we can use all kind of situation like use of music to reduce the anxiety. But we have to remember that the importance of the ability to do fast. Impact of anxiety levels depends from the time of our operativity. So it's important to stay one moment more in the counseling to understand which kind of patient we have in front of us, and if we are able to perform and to approach with the operativity in office hysteroscopy. In our mind, when we have the patient, there are like a scroll about the kind of patient and the kind of instrument that is proper for the pathology and for the patient. Sometimes we know that they ask if it's possible to have sedation or local anesthesia, but we know that it's not so important. And another kind of new is the hypnosis approach that I will speak about in a few minutes after. So it's important always the correct evaluation of the pathology before the hysteroscopy. And now in this symposium, we know that the importance of switch of the ultrasound examination and the hysteroscopy. So we have to be sure of the kind of pathology that we have in front of us, and if we are able to treat with the specific instrument one. And obviously the importance of time if we have a fertile patient. And the correct evaluation of the pathology, we know how many is important, because sometimes we don't imagine if the right solution is the kind of operative that we do. And sometimes the wrong evaluation can create problems like the impossibility to remove the pathology. Especially when we are at the beginning, we cut the pathology and we have problems to remove from the cavity. The two kinds of instruments that I spoke before is the mini resectoscope, that it's a very revolution for our office setting, but we have to put attention about the electricity that we have during the surgery, and if we are able to do that. So especially for who is not so expert, is very, very dangerous to propose to a patient awake. And our goal, we have to remember, that is the happy patient that goes away, and we have a mission that is to reduce the percentage, that is 30% for the patient that says that the office hysteroscopy is very painful. We arrived to the shaver instruments, that are the other kind of instrument that we can use. And this is another revolution, because we can propose in all kind of patient, especially for patients that has, for example, an anesthesiological problem. And we don't have electricity, so the learning curve is faster. What happens when we have a shaver? It's like something that eats very, very quickly, and we have always a good vision during the surgery. They started a lot of instruments. This one is one of the shaver that we have disposable here. And we have different kind of bladder. This depends obviously of the pathology that we can treat, from the polyp to the myoma. Here I want to show you the video that is the best example of the useful of this kind of instrument. Here you can see the timer, that it's the real timer of the polypectomy. And you can see how is clear the vision during all the procedure. And we finish the polypectomy of a big polyp, like you can see, in very, very few minutes, less than 1 minute. How is possible with other kind of instrument? So you can see the clarity and the possibility to see and follow the polypectomy during the procedure. And here you can see the grasp that you can use, for example, to remove the small part of endometrial tissue. Here another kind of application, that is the use for myoma, submucosous myoma. And here you can appreciate the ability to cut in a very quick time the myoma. And here you don't see, you see the small fovea in the endometrial tissue without bleeding. Another kind of application is the polyp and the myoma. Here you see directly the introduction of the instrument without dilatation of the cervical canal. And with a little push, we arrive inside the cavity. And we have the pathology, and we treat in a very quick time. You see the bladder is very able to cut, and we have the fovea after the surgery. Here another application is in this case, is a patient with abortion, and she wanted to do the cytogenetic examination, so we perform before an embryoscopy, and we remove the embryo to put the cytologic examination, and then we use the shaver to remove all part of the embryo. Here, another kind of application. This is a very strange case because in ultrasound, like you can see, the endometrial tissue is very thin, but we see in the corneal, in the ostium, left ostium, we see the residual of the abortion. And now you see the use of the classical mini resectoscope, but it's very, very hard to remove it. And you have to consider that we are in a place with a thin tissue because we are in the tubal ostium. So I change the instrument. I try to remove with cold instrument without success. And then the big idea, that it's like the title of the symposium, the light that arrived with the use of the shaver, because I was sure, because we don't have energy, and I clean in very, very small time this part of very dangerous part of the uterus, because we are like inside the tubal ostium. We can propose also for biopsia-oriented biopsia in case of endometritis on all kind of necessity to avoid, obviously, the DNC. And now I want to show a new, that is, for me, it's a very honor to give you my presentation here. That is the hypnosis technique in hysteroscopy. There is voice? Because you see now that the patient is completely sized. This is the anesthesiologist, but he doesn't do any kind of pharmacology, any kind of drugs. It's important to listen the voice here, because here you can appreciate the use of the shaver to cross through the cervical canal with small cutting of the cervix, like you can see here. The patient is completely awake, but is in hypnosis. Then I use the shaver to go through the cervical canal. And then with the small push, I arrive directly in the cavity. I cut, I use the bladder to open the synechia, and I arrived in the cavity. Then I use the filter to be sure of the kind of polyp, and then I remove it in completely awake patient. As you can see here, and the anesthesiologist. And finish, and when she wake, was very, very happy. Thank you so much.
Okay, so you see, we talk about moving from the dark ages to the light, because there are still procedures that we perform in the dark ages. We perform in a blind way. You saw here the use of new technology for DNC, in case of missed abortion. There are many, many countries that still are doing DNC for many protocol conception. And that brings me to our next speaker. I can see the presentation, please. It's the same, everything is with the same laptop, so please. The presentation. Okay, so we go again with the AI. I won't present the next speaker. She will present herself.
My name is Marta Simó. I am the head of the Obstetrics and Gynecology Department at the Arnau de Vilanova University Hospital in Lleida, Territorial Clinical Director of Gynecology and Obstetrics of the Catalan Health Institute, Associate Professor at the University of Lleida, Chair of the Hysteroscopy Special Interest Group of the Catalonian Obstetrics and Gynecology Society, and of course, passionate about hysteroscopy.
She will talk about present and future of the uterus, giving light to RPOCs. Marta, she is the chair of the SIG, or the Special Interest Group in the Catalan Society, where I'm a member of it. So it's a great pleasure for me to give you the stage, please.
Thank you very much. Thank you very much. I want to thanks to the organization for letting me participate in this really, really amazing conference. Thank you very much, Sergio. As in the context of our session today, I think it doesn't work. Sorry, is this one? It doesn't.
No, con este. Vamos para atrás. Ah.
This one. Is this one? Back. No.
Ya está funcionando, Venga.
Okay. In the context of today, of the session of today, moving from the dark ages to the light, I'm going to talk about I'm trying to give some light to RPOC, sharing with you our minimal invasive management of retained products of conception. I've divided my presentation into 4 parts. First, I'll give you a short introduction. Then I'll share with you our protocol we implemented in our department in 2021. Then I'll give you our results over a 3-year period. And finally, I'll give you a consensus document we drawn up from the Catalan group. Let me first introduce our hospital. Here you can see a map of Spain and the site of Lleida, where hospital is. We have a referral population of more than 400 inhabitants. I'd like to introduce as well the office team, the office hysteroscopy team in our department, and show you the room in where we perform about 25 office hysteroscopies per week. Here you can see the instruments we have at our disposal in our unit, mechanical forceps and scissors, mini resectoscope, and 2 morcellation systems. According to the International Consensus Statement for Recommended Terminology for Hysteroscopic Procedures, in our unit we perform hysteroscopies, pain management. We manage it with no medication or oral non-sedative treatment. We perform the exploration in an outpatient setting. The patients are admitted and discharged the same day in an ambulatory model of care. Most of our procedures were operative procedures, and we perform it with a vaginoscopic approach. Going to RPOC, the definition of RPOC is the retention of the trophoblastic tissue inside the uterine cavity after a delivery, a miscarriage, or an abortion. It is a complication that involves about 2% of full-term pregnancies, 6% after miscarriage or abortion, which goes up to 15% in cases in which pharmacological method was used. When there is a clinical suspicion of RPOC, transvaginal ultrasound examination is the gold standard method for the diagnosis. We have to pay attention to the appearance of the intracavitary material, especially to 2 important features: endometrial thickness and Doppler pattern. The Doppler pattern is important for ruling out a blood collection and for assessing the vascular pattern of the retained material. If RPOC is diagnosed, then the Gutenberg classification is a very useful tool to manage it. The Gutenberg classification classifies RPOC according to its echogenicity and vascular pattern. Here you can see in the top row the different ultrasound appearance of the different types of Gutenberg classification, and below its correlation with its hysteroscopic appearance. It's important to say that there is a correlation between the degree of the Gutenberg classification and the risk of bleeding during the surgical extraction, and this aspect has to be taken into account to decide the most appropriate time and method for treatment. When the RPOC is diagnosed, then we have 3 management options: expectant management, medical treatment, or surgical intervention. We decided on one or the other based on the severity of the symptoms, especially bleeding, the ultrasound appearance of the retained material, and patient's opinion. When we have indicated surgical management, we have 2 treatment options: DNC and hysteroscopy. Historically, DNC used to be the first choice, but it has to be considered that it's a blind procedure with many associated risks. Moreover, hysteroscopy is a minimally invasive technique with many advantages over DNC, which nowadays should be favored as the first option for surgical treatment of RPOC. Here you can see the advantages of hysteroscopy over DNC, and in this video you can check how minimal invasive is, as it only acts on the retained material and doesn't affect and then takes care of the rest of the healthy endometrium. Moreover, we have to consider that hysteroscopic extraction has many additional advantages, as in many cases it could be performed in the office setting. This confers many additional advantages, as no implication from surgical environment, avoids surgical and anesthetic-related risks, no need for hospitalization, and immediate return to daily activities. All of them clear benefits for the patients, the institutions, and as well for the health system. Now let's turn to our protocol. In January 2021, a new protocol for RPOC management was implemented in our department. Based on current scientific evidence, office hysteroscopic removal was proposed as the preferred option for surgical treatment. In our protocol, we encompasses all patients with clinical suspicion or diagnosis of RPOC after a miscarriage, an abortion, or a delivery. When there is a clinical suspicion of RPOC, a transvaginal ultrasound is performed with an endometrial thickness cutoff value of 15 millimeters, and then we assess Doppler pattern of the intracavitary material. If RPOC is diagnosed, then we classify it according to the Gutenberg classification. When RPOC is diagnosed, then our clinical attitude is always determined by the clinical signs and symptoms, especially bleeding, and the ultrasound findings. If the patient presents with acute and severe bleeding, is the only case in which DNC is the first option, but in this case, we consider performing it guided by ultrasound. We limit the scratching to the implantation site, and we made it with aspiration devices. In cases in which patient presents moderate or mild bleeding, and depending on its intensity, the ultrasound image, and the patient's clinical condition and preference, we can opt for expectant management or active management. If we opt for expectant management, we schedule a visit plus ultrasound in our fast-track dispensary at 6 weeks after abortion, miscarriage, or delivery. If at 6 weeks the RPOC is spontaneously solved, then we discharge the patient. If at 6 weeks the diagnosis of RPOC persists, then we schedule an office hysteroscopy to remove it. If we have opted for active treatment management, we schedule a preferably office hysteroscopy to remove the retained material. For asymptomatic women, we propose expectant management, and we schedule a control at 6 weeks after abortion. If at 6 weeks the diagnosis persists, we schedule an office hysteroscopy, and if it's solved, then we discharge the patient. If the diagnosis of RPOC is made in the primary setting, we propose the same controls there, and we only refer the patient to the hospital for office hysteroscopy when surgical treatment is needed. Here you can see the algorithm I've just explained to you about our attitude in RPOC patients. Now, let's show our results. We recorded our results from July 2021 to March 2024. We included all the patients with a diagnosis of RPOC being attended in our office hysteroscopy unit. We recorded 200 patients, the origin of RPOC in 94% of cases were abortion or miscarriage. 57% of the patients presented mild vaginal bleeding, and according to Gutenberg classification, 65% of them were classified as type 0 or 1. Here you can see a table with the instruments you used to remove the retained material. As you can see, 95% of cases we used morcellation system. In terms of resolution capacity, we achieved a complete resolution in one-time procedure in 86% of cases. A second office hysteroscopy was needed in 11.5%, a second operative time in 2 cases, and 2 cases needed a DNC. With this data, we can see that the resolution capacity of our office hysteroscopy unit is 98% of RPOC cases during the study period. In terms of pain management, 99% of patients were performed without anesthesia. The pain EVA scale during and 10 minutes after the procedure was 4.6 and 1.9. Most of the patients were satisfied, as most of them would recommend the procedure with our approach. And in terms of complications, 90% of the explorations were met without complications, 10% with complication, most of them mild complication, except one uterine perforation. Here, paper we published last year with our results, with a very similar data I have explained to you. And to end the results, let me share with you a personal reflection, because I've asked, do we really believe that we have to move from the dark age to the light? Have we really changed our clinical practice? Do we really change DNC for hysteroscopy? And to answer this question, I've analyzed the number of DNC performed in our department in the last years. And the numbers here you have. And I think that the numbers by itself answer this question. We have significantly decreased the number of DNCs performed in our department, meaning by 83%. In 2023, we only made 17% of DNCs we performed 4 years ago. It has to be said that in this reduction, it not only influenced the RPOC protocol, but as well we have introduced pharmacological management of abortion and miscarriage during these last years. And to finish, let me give you the consensus document with recommendations on the management of retained products of conception, we drawn up by the GISCAT, the Group of Interest for Hysteroscopy of the Catalan Group of Catalan Society of Obstetrics and Gynecology. Here you have the QR code that gives you access to the complete document, but let me outline the most important points. Once RPOC has been diagnosed, there are 3 management options: expectant, medical, or surgical treatment. The decision on one or the other must be based on the clinical situation of the patient, basically the presence of bleeding and its intensity, as well as her preference after having been informed. Expectant management in asymptomatic women or women with mild bleeding is an effective and safe option that achieves published spontaneous resolution rates of up to 90% at 6 weeks. There is no solid evidence on the waiting time, but in general, and if the clinical condition of the patient allows it, it is advisable to wait a period of time equivalent to that of menstruation, at least 6 weeks after the abortion or childbirth. If expectant management is not effective or the patient's clinical situation requires it, surgical removal of the remnants would be indicated. In this case, hysteroscopic extraction that acts under direct vision only on the retained material without affecting the healthy endometrium or uterine cavity should be the technique of first choice. Blind uterine curettage should be indicated only in cases of acute uterine bleeding and should be done without ultrasound guidance and limited to the area of chorionic or placental insertion to minimize the risk of injury to healthy tissue. Let me give you some take-home messages. The current literature supports superiority of hysteroscopy over traditional DNC for surgical treatment of RPOC. We should give light to RPOC, and operative hysteroscopy should be considered the surgical treatment of choice in women with RPOC. Our results after 3 years of experience and 200 cases support minimal invasive management of RPOC, which includes expectant management and office hysteroscopic approach as a feasible, safe, and effective approach to manage it. In our series, 98% of cases were solved in an office setting, and 95% of them took advantage of hysteroscopic tissue removal systems. And to finish, an inspirational phrase in line with today's spirit: every once in a while, a new technology, an old problem, and a great idea turn into innovation. Thank you very much.
Thank you very much. I want to open a parenthesis. I invite you, both of you, because probably there are going to be questions, a parenthesis. You know, in every Congress or in every big event, we leave the best for the last. So I would like you to be here, because when we finish that after lunch, the best session of the Congress, I believe, is going to take place. Basilio Stanos, Antonia Testa, Antonio Pellicer, and Luis Alonso, chaired by Attilio, by me. So it's going to be very special, because we are going to see a lot of innovation in the kingdoms, what's coming in the future. So I close the parentheses, be here, and enjoy also this session. So the symposium was about going from the dark ages to the light. As you saw, it's the present in many of the centers that we are performing DNC by direct visualization, not in a blind way. All for miscarriages until 10 weeks, that are common by practice in our hospital. And of course, RPOCs, and even are more uses. For example, visual DNC in cases of diffuse pathology, endometrial pathology. What do you think about this? Sorry? The use of visual DNC with tissue removal systems in cases of diffuse pathology of the endometrium. So instead of going and do curettage, do you have experience with that?
Yes, we have this device at our disposal, and we use it in our office hysteroscopy unit. We perform 25 office hysteroscopies per week, and we used usually these devices especially for diffuse pathology. We use them as well for example, big polyps, myomas. Yes, we use it.
Anyone has any question? It's your opportunity. In our hospital, yes, there's a question over there. Tfaddal.
Thank you very much. Antibiotics and post-procedure medications to reduce the bleeding duration, which I mentioned before. I struggled with several of my cases I tried. They come back, oh, we're bleeding heavily for 2 months. We're bleeding heavily for 2 months.
It's a good question. How do you manage, when you do this visual DNC for a miscarriage, to manage the bleeding, if there is any?
To manage the?
It's due to the decidual, you know, we don't scrape anymore. So I found all my patients, actually the ones I've tried, they come back and say, we are bleeding heavily for 2 months. So should we give them something, or misoprostol and antibiotics? No. Or
in cases of RPOC,
yeah.
As we have expectant management, most of them have a low degree of Gutenberg classification. Then usually they don't bleed a lot. So usually, as you can see, 65% of our cases, as we have introduced the expectant management, most of them don't have a very high pattern of Doppler. So you don't have very often the problem of bleeding. I think that it's an important issue when you have to decide the moment of the treatment, to take into account the Doppler pattern to decide if it's time now to remove or you can wait. The more experience we have, the more weight taking into account the Doppler pattern of the material, obviously if the clinical status of the patient allows it.
But waiting long with miscarriages increases, we all know, risks of infection. So
sorry, because no, generally no. For the increasing of infection, no. You can control by ultrasound and the situation of the patient. I use
no. We don't use antibiotics. Preventive, no.
Linda Bradley, she's very pro direct visualization, against DNC.
Thank you for this session. It's excellent. Let there be light, right? My question is, any of you have experience treating molar pregnancies with tissue retrieval system?
From the molar.
No, we only have experience of one case that in one RPOC, the pathologist says that there was a mole pregnancy, but no to evacuate a molar pregnancy, we don't have experience.
No, neither me.
Any other question? I can tell you what one of the big advantages in office, until 2 centimeters, is very easy to remove with mechanical instruments. But when you have a big tissue removal, a big remaining post-conception, sometimes a piece of placenta that it's a small piece of placenta, but when you look inside, it's 4 centimeters. It's very difficult to remove with mechanical instruments. Even with the small mineral stethoscope, it's very difficult because it's very big. But when you take these products, these devices, you just to attach it to the tissue, and it does the work. But sometimes we have problems with the visualization due to the bleeding. That's the important question. How do you deal with this bleeding? What's your strategy?
Generally, we wait, only waiting. If you wait...
During the procedure?
Yeah.
I think it's important as well to have a good system of fluid management.
Good
I
pressure.
think this is important, and to play with the pressure and with the flow. But in our case, I think it's important to prevent this bleeding complication and to take into account the ultrasound images.
So, in your experience with the 200 patients, what was your average fluid absorption? And I've noticed my patients getting very cold, where we have to bring in blankets. They're shivering like after delivery. Do you use warm fluid saline or just room temperature? And
no, yes, we warm saline.
Me
yes.
too.
Yes, yes.
What was your average absorption?
Sorry?
No.
Fluid, how much was absorbed?
We have an automatic system, but many of exploration are so short that
not very much.
It's not significant.
You have to control
the fluid management, when you have a good system, these procedures are very, very fast.
Very
to
fast.
To the way it works. So it's difficult to arrive to an overload of fluids in those kind of patients. Tony?
Just a quick question. How do you decide which device to use? You use the XL, do you use the Reach, the Light, which one?
It depends from the measure of the pathology and the kind of pathology. The XL, for example, you use for myoma or a big pathology.
Let me explain, because I don't believe many people know what's XL and what's Reach.
Okay, sorry. Before.
So these devices come in different sizes. The Reach, the good thing about the Reach is that the window arrives to the end of the device, so you can get into the cornea to remove tissue from there. That's the advantage, and it works with a scope of 5.5 millimeters. That's the one I use in office. Then you have another one with 6 millimeters, in which you can use the XL that has a big window, and it's excellent for fibroids.
For fibroids, yeah.
Now they understand it's easier.
I give for sure.
In the office setting, we usually use Reach.
Reach, the most one.
Yeah,
and it's enough Reach for
the
soft
more
tissue.
Common
It's very fast.
We use.
Very fast. What do you think about I know that we all work with the fluid management. In my case, the tube of the suction, I close it with my finger sometimes in order to get a better vision. What about strategies for reducing bleeding, like tranexamic acid in the cell line, or giving it to the patient? Do you have any experience with that, or anyone?
In the office setting, no, because usually we perform short exploration with no very complicated. Now we are starting with myomas, and I don't know if we are going to change, but so far we don't need it. In surgical environment, then probably, but in some kind, for example, big myomas, in that cases, we don't use to use it, but we are thinking about it.
I never use it.
Okay,
never.
Perfect. Any more questions? I know that for many to think about, because the most easy procedure, the most used procedure in any department is the DNC. What we teach our trainees. You sit down, you go at 12 o'clock, 1 o'clock, 2 o'clock. And most important, when you finish the whole o'clock, you must feel the endometrium. It means we took the whole endometrium out. And this is not good. By this, or using assisted hysteroscopy evacuation, you are focused where the implantation is. And the probability of having adhesion and compromise in the fertility of those patients drops down. That's the important thing of it. That's why I don't like doing DNC. And in all pregnancy until 10 weeks, we offer medical management, or if we offer, we started 6 years ago, if we offer surgical, it's always focalized on the implantation without damaging the whole cavity. And that's the good things of these devices, because they bring us from the dark ages of the DNC to the light and to be less harmful to our patients. Any other comment?
The message is that we don't use DNC, never. I never used that, never in my life. So I can tell you.
And you saw, Marta, it drops by 83% the use of DNC, and I believe this is the future.
But we speak about this by a lot of years ago. Yeah. We don't have to speak another more.
The cutoff of 50 millimeters, if it's above 50
yes,
millimeters.
There is no international consensus. There is no solid evidence on the cutoff value, but most of papers used 15. I think it's a pending subject to generate solid evidence in this aspect, but. Some papers takes 10, 12, 15, but most of them take 15, and that's the why we take 15. If it's more than 15, no, over 15, then we consider the diagnosis of PRC depending on the ultrasound appearance and the Doppler pattern. No, 15 millimeters is the limit to diagnose RPOC, not to do the DNC. 15 millimeters, if you have a patient that has abortion, miscarriage, or delivery that is bleeding, we perform the ultrasound. If it's over 15, we consider the diagnosis of PRC. If it's under 15, I think we consider that there is no RPOC. Okay. It's the limit for the diagnosis, not for the treatment.
So, time is out. I want to thank Hologic for the support. This is a Hologic symposium. Thanks, Marta and Eleonora, for the wonderful presentations, and thank you very much.